lives. Here he is from TI International Woundpedia. Let's give it up for James Elliott.
All right, hello everyone. First time in Thunder Bay. That's very beautiful. I like that hill out there. I don't know what it's called, but it's very pretty. So I'm representing Woundpedia, which is a group dedicated to open access knowledge about wound care, of which diabetic foot is a major wound issue. Also T1 International, which is an international charity dedicated to type 1 diabetes, especially people living in poverty. And today we're going to be talking about diabetic foot care, or diabetes foot care, and saving limbs, saving lives. And before I begin, I want to say that I appreciate the invitation. I want to give thanks to SOTI, I want to give thanks to NADA, and I come here in a spirit of openness and a spirit of respect for the Aboriginal cultures, and also I want to learn more about these Aboriginal cultures, so come and tell me about them. So here we go. For lack of better words, I'm a researcher or advocate, which means I study stuff, I research stuff, and I also try to get what I study and research into reality, which is another word for advocacy. Again, I'm a trustee for T1 International. That means I don't take money. I'm a consultant for Woundpedia, which means that's how I pay my bills. I'm a person living with type 1 diabetes, and I self-identify as such, and I have no financial interests at stake with this talk. So we got three things we're going to talk about. One is diabetic foot prevention, the second is diabetic foot treatment, and the third is advocacy stuff that's going around diabetic foot that we want your help in, and maybe you can help us. So the first is prevention. So to begin with, when we talk about diabetic foot problems, people who don't talk about diabetic foot problems a lot think that it's a bad thing that happens to you, and it's a real inconvenience, and it's a real pain in the behind. But when we actually look at the mortality rates about diabetic foot ulcers, another name for diabetic foot wounds, they're actually worse than many cancers. So from this graph, you can see the circles are over neuropathic ulcer and amputation. So you see around 50% of people who undergo a diabetic foot amputation or have a diabetic foot ulcer will be dead in 5 years. And that's actually worse than breast cancer, that's worse than prostate cancer, and that's worse than Hodgkin's disease. So these are life-threatening situations. Now this is Dr. Gary Sibbald's slide. So for those of you who don't know Dr. Gary Sibbald, he's a big fan of mnemonics. So when it comes to diabetic foot prevention, you can break it down into 5 S's. And we're going to be talking about each of these S's, but to begin with, it comes down to screening, stop smoking, shoes, systemic control of blood glucose and BP, and also skin temperature. So we're going to talk about screening first. Now, the overall picture in Canada is pretty abysmal when it comes to diabetic foot screening. You see, this is data from the Commonwealth Foundation. So basically, they're a group in New York, which is kind of ironic given that they're called the Commonwealth Foundation. But anyways, they go around and they call patients in different countries. They call a couple thousand of them for each of their studies. And they asked people living with diabetes, have you had your feet checked in the last year? And if you look, there's Canada on a lot of diabetes metrics. And only about 52% of people with diabetes in Canada said, yes, I had my feet checked in the last year. Now, if you go over, you see the different columns are Australia, that number was 57, New Zealand, that number was 66, United Kingdom, 75, United States, even the US was doing better. So we always like to harp on the United States, but when it comes to diabetes care, in this element anyway, the United States is beating us, Obamacare and all that. So the point is, only about half of the people who need the foot exam every year are getting it, and we can do a lot better than that. So, not to be too prescriptive about what screening tool you should use or what screen you should apply, but the 60-second screen is available. It's free to use, and I'll let people who are write, so I'll talk very slowly now, but it is available at woundpedia.com, and also if you Google simplified 60-second screen plus diabetes. And that's what it looks like. It's free to use. There's no copyright or whatever. You don't have to pay anyone. And it's also available in multiple languages. So I highly encourage you to check it out. There's also a YouTube video that you can watch it being applied in 60 seconds. And there's training available that happens periodically. And again, this is just to show that we publish openly. So you can look up why the 60-second screen is valid. It was a validation study that was done. It's published in PLOS One, so Public Library of Science, and anyone can download it, so I encourage you to do so. Now, the second of the S's is stop smoking. Easier said than done. But you could spend a whole career on smoking cessation. Indeed, many people do. I mean, that's people's whole jobs, is to do smoking cessation. So to distill it down into a minute, you have to be culturally appropriate, especially, not even especially, with any culture. So whether that's, you've got people who are from Aboriginal cultures, you've got people who are from Arabian cultures. Be culturally appropriate. And I actually picked this up from Chief Day back in August. I met him at a conference in August, and he said the messaging, which is good to use, is limit non-traditional tobacco use. So it's not stop smoking cigarettes, you have to limit non-traditional tobacco use, because of course there are traditional uses of tobacco. So a good example that I found is the Wabano Sacred Smoke Program. I don't know if anyone here from Wabano is, yeah. Well, there you go, talk to her. It's a good program. Yeah, so there you go, that's easy. And, but for everyone, you should be conveying the reasons for stopping to smoke very simply, but very accurately. So again, it's not this general, you'll get lung cancer and stuff. For diabetic foot, smoking physically decreases the blood flow to the feet. It physically decreases the blood flow, and you need blood flow there. So it's going to decrease your chance of healing, and it's going to increase your risk of problems. Another good resource to check out, so again, I'll talk slowly so people can write it down. Lessons Learned in Ontario, Aboriginal Tobacco Cessation, and this is freely available from Cancer Care Ontario, but it gets into case studies and different programs that have been tried, different tips. But yeah, and I think the slides will be available, so if anyone wants to, or ask the nice lady from Wapano, because she'll point you in the right direction. Actually, I have no idea if she will, hopefully. So third S is shoes, which in diabetic foot parlance is also known as offloading. In other words, offloading the pressure. So to skip over this, shoes and everything that goes with them. So socks, the offloading devices, the plantar pressure redistribution boots if needed. These are not optional. These should be considered core elements of diabetic foot care. These are not nice things to have. If you have a wound on the bottom of your foot and you keep walking on it and it won't heal, it won't heal. Like it's very simple. Yet there is no public coverage in Ontario and a lot of other provinces for diabetic foot care. They'll pay for the amputation, they'll pay for the ER visit, but if you need the couple $100s to get yourself one of these boots or you need some socks, that's out of pocket, and that's ridiculous because even the United States, again, the big evil United States, they pay for it because it makes a lot more sense to put $100 down than to pay $70,000 for an amputation. So if you want to work towards this, there's an ongoing advocacy effort going on between the Registered Nurses Association of Ontario, as well as the Canadian Association of Wound Care, and 50 other organizations and people who signed this open letter to the health minister. So if you Google diabetic foot open letter, that'll be the first thing you see. But I'll be here tomorrow and the rest of the day, you can talk to me. But we're trying to generate pressure to get this into reality because it's absolutely ridiculous. And there's some other demands in there as well, but I'll talk to you offline about that. Fourth S, systematic blood glucose control, as well as BP. So I like this. Does anyone follow type 1 diabetes memes? I'm the only one? Is no one else? Okay, fair enough. But if controlling blood sugar was easy, everyone would do it. And that's the simple reality. And I see a lot of people who are in the diabetes world, but they lack the empathy a lot of times with their patients. And just having type 1 myself, it's not easy even if you do this for a living. Even if you study diabetes education for a living, it's not the easiest thing. And this is a study that basically shows that 2% of a person's blood sugar is going to be controlled by what physicians and what their providers do. So in other words, what insulin they're on, or they switch from 4 mealtime units to 5, or they got a prescription for whatever. 98% of a person's blood sugar is controlled by what they do. 98%. So that's everything, it's the 1,001 decisions that you do from sun up to sundown. Again, won't spend too much time, but you can break diabetes education and self-management and support into 4 core elements. Some would say there's more than this, and there probably are, but To simplify, it comes down to the education, especially around diagnosis. And I think we talked about earlier that diagnosis is often a traumatic event and it needs to be respected. I mean, I've seen people being diagnosed with diabetes in 5 minutes, and that is appalling and shouldn't happen, but yet it is. Also diet, exercise, medication. And again, it's should be specific to the impact on blood glucose. So you're trying to form more or less an algorithm in the person's mind. You know, it's not I should exercise because exercise is good. It's I should exercise because one, you know, my muscles will take in a bit more sugar and that'll make the peaks less intense and I can go to the bathroom less often. You know, it's all about forming that algorithm in the patient's mind. So another thing that you should be aware of, I'll read this out. Anyone see Maury? No? All right, your written blood glucose log shows you had been having good blood sugars lately, but your HbA1c test determined that was a lie. Right. I mean, it's funny, but again, why are patients lying to you in the clinic? And that's because your face looks like that, you know? So the research shows that a non-judgmental, a non-confrontational, a non-adversarial approach is more effective. And it's not bogus. You know, there's actually, people have tried different techniques of doing diabetes education, and the non-confrontational, the non-judgmental way simply works better. You get better patient outcomes, it's just better. So don't look like that. Or if you do it where they can't see you. Another program, again, if you want to write or if you want an introduction, there are a couple of us who know CAWC people and are CAWC people, but Pep Talk is a pure diabetes education program around the diabetic foot, and I've been told it has been adapted to, I forget exactly which Aboriginal community in Manitoba, but there are adaptations for Aboriginal communities, and I think they would be open to adapting it further. But again, the power of peer management, the power of peer talking, it's very much a thing in diabetes and it's very much a thing in diabetic foot. Prevention, but also prevention of reoccurrence. And the last of the S's is skin temperature. So this is kind of a new thing, but you know those infrared thermometers you can get and you check like your truck's temperature manifold, like you know the engine manifold to see if it's too hot, or you know, if any of you have carpenters in your family, use those infrared thermometers, and they're like 20 bucks at Canadian Tire. Well, there's actually been research to show that this is a good diagnostic tool because when there's more than a 4 Fahrenheit degree difference or a 2.2 Celsius difference between the feet, that's a sign of problems. And that's a sign that, you know, you're either looking at the early signs of infection or there's something else going on there. And this has actually been adapted into patient self-monitoring. So actually just giving them the infrared and letting them themselves measure the temperature differences on their feet. And once they see that temperature difference, they know there's a problem, they know to seek medical care, they know that they should be more active. And this is actually a series of studies done in the United States, and you can see that basically they went from 20% reoccurrence to 2% reoccurrence just through infrared. Now, that's just one study, but there's definitely a difference there, and there's research to support that. And probably the most cost-effective strategy is to get them to take off their shoes and just look at their feet, because you know, hands up if you've ever been in clinic and you found a diabetic foot ulcer that the patient didn't know was there. 1, 2, it happens, you know, 3, 4, there's lots. So take off the shoes. Treatment, again, won't get too much into this, but another acronym, VIPs with the S. So when it comes down to treatment, it comes down to vascular insufficiency, treating the inflammation and infection, pressure downloading, so getting rid of that pressure, and for some cases, surgical sharp debridement. And again, callus is a sign of pressure, and then blister is a sign of shearing. So again, this comes down to treating a whole patient rather than a hole in a patient, which again, I can't take credit for that, but that's Dr. Sibaldism. But it's true, you have to treat the whole patient. So a lot of people in wound care, they go straight to what dressing is this? Is it a this? I get put it on this. But you have to look at the factors that are in the patient's life and address the family concerns. Again, this is open access, so you can look at Wound Bed Preparation 2015, download it, but if you want even more information, you can look into taking the International Interprofessional Wound Care course. So this happens in Toronto as well as a lot of other places. And we've actually been successful in getting some LHINs to pay for people to attend, also some health authorities in BC. So if you're interested in learning more about wound care, we can work with you to try to get the funding. But it's a year-long course. If you don't want to dedicate that, we've got Project Echo coming up. And again, I want to say I'm going to be around, but Project Echo is essentially a tool for primary care to train up to near a specialist level in a certain thing. So there's a project right now about mental health. So there's also a project on pediatric mental health and also pain and opiates. We're hoping to be the wound care Project Echo. So what this is on Wednesdays for 2 hours, you'll get to phone in, essentially using a Skype-like technology, and you'll get a 20-minute lecture on a specific subject around wound care. And for the rest of the time, you yourselves will be talking about your cases. And you yourselves will be working them out with the other learners, but then also you'll